Tonight I have the opportunity to introduce to you two gentlemen that are going to speak on MRI imaging of the prostate and precisely guided biopsy with the imaging. I have Mr. Dan Gentz. Stick your hand up, Dan.
Hi.
And he's going to come up and do the speaking tonight. And Mr. Armando Benard, he's going to operate the equipment here so that Dan will give you a good presentation. Dan will present the newest capabilities and applications of their magnetic resonance imaging systems. He will discuss the differences between MRI and CAT scans, and that's always very confusing for us. With data regarding recent advancements for MRI. He will also elaborate on who should and who should not utilize MRI imaging. Perhaps the most important capability of these new MRI systems is the ability to use the image for greater precision in guiding the biopsy needle. I'm going to take just a minute and digress there and show you just how important that is. I'm going to get a little bit personal. In my personal experience with prostate cancer, I had two biopsies. One when I had a PSA of 7 that had been climbing for years, 6 or 7 years, and then 2 years later when it got up to 10.5, I had another biopsy. Both of these biopsies proved negative. I went to Duke Bond and he said, I don't see how they missed it, but it's irrelevant. The point is that the urologist that did these two missed them. If he had had the ability to use this MRI system that we have today that we're going to talk about, perhaps I wouldn't have advanced prostate cancer, which I have today. So this is just how important this can be. It's sorry to digress and get personal, but I feel strongly that what they have to offer is going to be of great benefit to the prostate cancer world. The use of these advanced tools for real-time image analysis should return fewer negatives when there really is prostate tumor present. That's what I needed. In Vivo is the leader in the world of MRI applications and monitoring, and it's my pleasure tonight to present to you Dan Gentz and Armando Benard. Dan, come on up, please.
Thank you. I think, thank you everybody for coming, by the way. I know it's a World Series night tonight. We always seem to be able to do these. I run these shows for my company throughout the West Coast, and it always seems to be a major sporting event every night we have one of these. So we're always competing with the World Series or the Super Bowl or something for some reason. So I appreciate seeing everybody tonight. The two most important things we're going to show you tonight are these two signs. Where's that sign? Right behind me or right in front of me? There and there. I'm a sales guy. I've been a medical sales representative for about 30 years, and as my wife would be plain to tell you, I'm not a doctor, but I play one during the daytime. So this is pure sharing information. My company has developed some products that we think are advancing the diagnosis and the intervention of prostate. The second important thing to know tonight is normally we have some slides up here that talk about urology and how they partner with us and how they don't partner with us in some of these cases. So I want to keep in mind that Dr. Weissman, who is a very well-renowned urologist, is in the room tonight too. So I'm going to have to kind of defer and watch his face once in a while when I'm making these presentations to see how things go. So before we get started, one of the main areas that this technology has been out for about 2 years, and the big difference that Russ had mentioned, there's a difference between CAT scans and MRI. And CAT scans, first of all, let's see if anybody's had an MRI for prostate in this room. Has anybody had a prostate MRI? Okay, good. And how about CT? Has anybody had a CT for prostate? Okay. So the MRI, it does not have any radiation. It's radiation free. It's basically taking the water molecules in your body and they'll put you in a high strength magnet and they'll all uniformly go into one direction, and then we ping it with an RF waveform that makes them move around in a certain way, and that energy that emits by moving those protons around gives you an image. So you'll see some MRI images. It's really good for soft tissue stuff, and it's really good for some of the things that we'll show you in staging of this disease. So that's the main difference between CT and MRI. But before we get started, one of the first adapters of this technology was a little imaging center out in Palm Springs, California called Desert Medical Imaging, DMI. And they got our system about 3 years ago before we released it even to the public. And they started doing some of the early scans on it. And about 2 weeks ago, this was run on the local television station out in Palm Springs. So I wanted to share this with you because it kind of gives you a background of what's going on in the world of MRI prostate. So Armando, why don't you start this? It's kind of dependent on the internet, so we'll see if we can get this thing going. You know, I bring Armando along for one thing, and look at he loves it already.
We're having technical
You're
difficulties.
fired. Let's try to see if try to get this line up again. Here. Yeah. Reload it there. This should just fire
Well,
ineffective in the early detection of certain types of cancer, including prostate cancer. We spoke with a local doctor and a prostate cancer survivor who believe the report by the government will not only delay prostate cancer detection, but could flat out cost people their lives. Prostate cancer specialists are pushing back against an expert panel's recommendation that healthy men should not get PSA blood tests for detecting prostate cancer. Dr. Stuart Bay is one of those prostate cancer specialists.
It came from the U.S. government, and anytime things come from the government, you're always going to be suspect these days, especially with all the new regulations coming forward.
The U.S.
Oh, that's what happens when you have internet in the back of the room. So try hit and play one more time. If not, we'll just go into the presentation. Yeah, we just can't get a good internet connection. And the only way to show this. The government recently came out with a report that said PSA is doing very little to demonstrate prostate cancer. So there's some new guidelines to it. And what we're going to show you tonight is a new technique that combines with PSA. Go ahead and go into the presentation, Armando. Sorry about that. Okay, so let's first run through some of the numbers. Obviously, prostate cancer is the most frequently diagnosed form of non-cutaneous cancer in men, which means non-skin cancer. It accounts for 25% of all cancers. It's the second leading cause of cancer death in men. And approximately 1 in 6 will be diagnosed with prostate cancer during his lifetime, and 1 in 35 will die of prostate cancer. These numbers are very, very similar to breast cancer. It's 1 in 4 in women, and it's about 1 in 40 in women will die. So the numbers line up. And why that's significant is we've been doing diagnostic and interventional work with breast cancer through the MRI for years. And if you would tell, in the 70s for a woman to have breast cancer, it was a radical mastectomy. And then in the 80s it became lumpectomies. And then the 90s, it became more radio controlled and some other opportunities to save the breast. And if you would go tell women today that there is a serum test in your blood to detect breast cancer, and we're going to blindly poke your breast to see if we can find what it's telling us, and then if we can't find it, we're going to take your breast. I don't think that you'd be real popular with that diagnosis, but that's exactly what we're doing with prostate cancer. PSA is a serum blood test that tells you something might be going on. Then there's an ultrasound trust biopsy that they do, that they blindly poke the gland, hoping to catch this cancer, which is the equivalent of taking a straight pin needle and poking a small line and looking for something that's smaller than the straight pin needle. So occasionally they'll hit, but oftentimes they miss. So I'll show you some of the numbers on that. So what we're talking about tonight is getting a better form of finding exactly where the cancer could be, diagnosing it, and then going and getting it under MRIs. Next slide. So 70% of the cancers are in the peripheral zone, what they call the PZ zone. Why that's important is the PZ zone is very difficult to get under ultrasound. So 70% of the time you're starting off with a difficult position to start with from the get-go. Go ahead. The two ways you screen for prostate cancer right now is DRE, which is digital rectal exam. The sensitivity is 37%, very low sensitivity. And the PSA blood serum test, this is where all the controversy is right now. The reason there's so much controversy about the PSA test is two things. One is there's a 75-year-old man in Tucson, Arizona, who's never had a PSA test done in his life. That man was the guy who came up with the PSA test. He doesn't believe in it. He doesn't think, he wishes he never discovered the PSA test because he thinks that it's caused over-treatment of the disease in this country. And the reason is, 15% of the men walking around with a PSA of less than 4 in this country have a cancer, have a known prostate cancer right now. 70% of the men with a PSA over 4 have a cancer that would never kill them. Yet we're treating these with all kinds of therapies and radiation and radical prostatectomy. So it is underdiagnosed and overtreated in the country. So what can we do about this? And this is I'm going to skip through a lot of these slides because some of this is clinical, but the New England Journal of Medicine did a blind test of guys having digital rectal exam and PSA screening, and then they just had guys that came in, without any kind of screening, and the mortality rates were exactly the same. So the screening was not doing anything to improve mortality rates in prostate cancer. So the gold standard right now is trust biopsy. Who's had a trust biopsy here? Has anybody had an ultrasound trust biopsy? Okay, pretty good percentage of you. What a trust biopsy is, obviously there's 1.2 million done per year. They take an ultrasound probe and they'll insert it transrectally, and then they'll take a needle and do a sextant biopsy around a certain pattern of the prostate gland. And one of the problems with that is some things are difficult to locate because the needle's about 1.7 millimeters, and sometimes these cancers are at 2 millimeters, so you can't get in far enough. The other problem with that is the prostate gland moves a lot. It's not stable. It doesn't sit right where you want it. So as you poke this gland, it's moving around. So you got a pretty low percentage of shot of getting this thing. So sensitivity and specificity are sensitivity is low, specificity is a little higher on that. But they have a false negative rate of 30 to 35%. Now here's the interesting thing. Who's had a second trust biopsy here? Okay. How about a third? Anybody had a third? Okay. So these are the guys that they say, all right, I missed it. I'm going to go back in and do it again. And the problem with that, and again, Dr. Weissman's in the room, but this is what they've been doing for years. One of the problems with that is that they're doing typically the same pattern with the sextant biopsy. The needle's not getting any longer on your second. And after the first, you've kind of done some damage to the prostate gland. So you have to wait a couple weeks before you get a second and third. So that's why this detection, we call it the detection yield, goes down significantly. Because that means that it's somewhere where you're not going to get it with trust, and it's more difficult to get, and you've also done some damage to the gland already. And they're not, and raise your hand if you think it's been a comfortable procedure, if it was enjoyable. That's always a 0. I have not had a taker on that yet. So it is a very uncomfortable procedure. Urologists typically do it in their offices, but until recently, this is what they had to try to find this. So let's talk about saturation biopsy. Now, again, Dr. Weissman, forget that last, this is from a doctor's presentation, not mine. This is Dr. Feller's. But what happens is occasionally they'll go to a random, instead of doing a random sextant biopsy, they'll go to a saturation biopsy. And what a saturation biopsy is, they'll put this grid plate between the rectum and the scrotum, and they'll do 60 to 80 cores, where they're just firing across to make sure that they get the entire prostate gland. And this is kind of referred to as radical prostatectomy through needle sticks, as far as most people are concerned. So here's the dilemma the urologist is faced with today. You got a rising PSA, and you got negative trust biopsies. So This right here is a huge concern. You have no diagnosis. So basically, the urologist is saying, you've got something going on with a test that we think can show you what's going on, that you might have a cancer, but I can't find it. So we're going to put you into active surveillance or watchful waiting, and we'll see if it gets big enough where I can find it under trust biopsy. So with all cancers, early detection is the key, because your volume of opportunities and choices is much greater when you catch it early. If you catch it too late, as Russ said, then there's different approaches to it. But if you can catch it early, you're going to be in better shape and you'll have more options. So what most people do, jump back real quick to that slide, what most people do with this, and it's interesting, when I talk to urologists and oncologists, they'll say that when you have a rising PSA and no negative trust, a lot of people, the guys seem to think, I'll wait on this. But the wives often call late at night or early in the morning and say, take this prostate gland. I don't want him to take chances with the prostate gland, because the way men kind of deal with their health is it'll go away, it'll get better. We'll ignore it, it'll get better. And wives make most of the choices in the medical care in the household in most families. In fact, when I do these talks, it's usually 50-50. Tonight it's a little more men than women, but it's usually 50-50. And I had a woman at the PCRI conference a couple weeks ago bring her husband up and said, this is the prostate. Talk to the prostate right here. And she referred to him as the prostate. She was doing all this research and everything. Have any questions, talk to the prostate. So a lot of times they'll go to radical prostatectomy to solve this problem. So we think the approach might be a little better with what we're offering. So go ahead with the next slide. So what they'll do is they'll take these weighted images, T1, T2, or MRI weighted images that show you different things, and then they'll use diffusion and they'll use this contrast. What they'll do is they'll inject contrast, and contrast going through cancerous or highly suspicious lesions will have an uptake, because cancer all needs nutrition. All cancers need nutrition. They need glucose, they need blood flow. So cancerous tissue has a suspicious characteristic that it'll take an uptake of this gadolinium dye that goes through your body, and then it'll wash it out real fast. So it's real porous. It just kind of like a sponge. It just goes right through it. Whereas normal tissue will have an uptake, and then it won't have a drop off. And that'll be important in a second when I go over kind of what we do here. Go ahead. So what they're looking for, this is a T2 weighted imaging. T2 weighted images show highly suspicious tissue that's dark. And you can all see where that arrow is right there. This is the prostate gland itself. So I'll show you in a minute what an ultrasound looks like. This is the prostate gland, so you can clearly see the anatomy of the prostate gland. You can see the zones, you can see exactly where it is, see what's going on. See that dark spot up there? That's a highly suspicious. So then they'll take this, what happens is they have this thing called cellular packing, where water movement will be stopped by cancerous tissue. The cells pack in, so water doesn't go through it so fast. So they'll watch water movement in this diffusion weighted image. So go ahead to the next slide. So in these ADC maps, you'll get a real dark spot up there. Again, you can see, this is what most the doctors that do this call this light bulb medicine, where you can grab a janitor or somebody in the room and say, where's the suspicious area on this prostate? And the guy can go, that dark spot right there looks bad. You don't need a medical degree for that. And then they'll take these B values down here, and they're doing some really interesting studies in the Netherlands right now, that these B values correlate to how dangerous this cancer is. So as the B value goes up, the cancer is becoming less dangerous. As the B values go down, the cancer is more dangerous. It's more lethal. So go ahead again. So they look at all these histologies, and they look at all these things, and they correlate them one more time. So this is the DCE technique. They'll inject gadolinium, they'll do a scan, and then they'll find out what happens with these curves. So this map is based on how fast the intake goes in and comes out. And they'll put a color to that. So the red areas are fast intake followed by washout. And we've been dealing with this with breast for 5-6 years now. Every breast surgeon, every breast radiologist in America knows what these curves do. They know what it looks like, they know how suspicious it is. And now we've taken it and translated it into prostate. So anything that's red says, look here, you might have a problem. This is something that's hot, it's a hot spot. Take a look at this. And then you correlate it with all your others. Dark on T2, dark on ADC, light on diffusion. In red, there's a 98% chance that's going to be something clinically significant, which means it's over 5 millimeters in size, and it's also got a Gleason score of 3 plus 4, or 4 plus 3 per 7. So go ahead again. So these are the curves. So this computer that we have automatically generates this. You can see wash in followed by wash out. That's highly, highly suspicious tissue. Now, a lot of guys stop there. They'll just say, okay, I'm going to give this information to my urologist and say, you've had 3 negative trusts on this gentleman. We think something's at 12 o'clock. Take your sextant biopsy and trust and fire it at 12 o'clock and see if you get it. And sure enough, the guy calls back and says, damn, how'd you know that? I've been trying to hit this thing for months with this, and I got it in the first pass because it's targeted it. So we took it one step further. We said, why don't you do it under MRI? Take the same information and go get it under MRI because you have the tissue and you have good anatomy with the MRI. So, go ahead. These are, if you put all 3 together, the ROC value is 91. That means there's a 91% chance that it's clinically significant. Go ahead again. Again, most of this stuff is. So, these are the multi-parametrics. Patients should be off of these hormone therapies when they do this because it screws up your scanning, but if you don't have, they'll get you off the hormone therapy. And then you have to schedule these at least 6 weeks after your trust biopsy. That's how much damage those trust biopsies do to the gland. You can't see anything when the gland's all hamburgered. So they wait 6 weeks for everything to repair, and then we do it again. So this is what we're talking about. See that image on the top right? That's an ultrasound. An ultrasound just tells you where the gland is. And for those World War II enthusiasts or anybody that's had any military background, we call this trust biopsy carpet bombing. You know, back in World War II, they would just take a B-52, fly over a city and bomb everything in the city, just hope they got the bad guys. And now, this MRI targets the tumor within the gland. So we're going after the tumor within the gland. And now we call this laser guided. You know, the stuff they have now, they find the guy in his back, you know, in his house, and they drop something down the chimney, and it doesn't do any collateral damage, and it just takes that guy out. And that's what we're talking about here. You can go target this thing specifically and get it. Right? So here's the problems with trust biopsy. Can you see this? Important cancers are missed. This needle's just going in here, and they'll pull this out, and they'll do 12 to 15 of these. But if the cancer's way up here, they're not going to get it. Oftentimes they'll go right through it, so it doesn't have anything on the lesion tip, and then oftentimes they can't get to it. So 3 distinct problems with trust biopsy, and that's why they're so low. And then the bottom point is really key. 36 to 46 of these Gleason scores are undergraded with trust biopsy. Why? Because they're not getting the malignancy. If this is the hottest spot in the tumor, they're getting this, and they're saying, well, it's a low-grade tumor, it might be a Gleason 3 plus 3. We'll put it on a slide, they'll check it, they'll say 3 plus 3. They'll come back and get an MRI, they target it, and it'll be a 4 plus 4, 8. There's a big difference between how you handle a 3 plus 3 and a 4 plus 4. Very big difference in mortality rates. Go ahead. So this is a couple examples of some cases that they've done. This is a 62-year-old patient. This was one of the first patients they did under MRI out in Palm Springs. Big-time Hollywood producer. He didn't want to have a radical prostatectomy. He was 62 years old. He had a PSA of 28. He had 8 negative trust biopsies, 96 cores taken. Nothing. So this is what they found. Go ahead. So this is why he's had 96 cores. This is the length of the needle for the trust biopsy. Tumor's way up here. There's no way they were going to hit it. They could have done 196. They weren't going to get it. Okay. So the Gleason score is generally used to predict the aggressiveness of the tumor. And then trust biopsies are really hard to accurately get the Gleason scores with. Go ahead. So, go ahead. This is the tumor detection rate with MRI. Remember the ones that I showed you earlier? First trust is about 30%. Second trust is 15%. Does anybody remember what third trust was? 8%. Yeah, 8%. So now you got about a 59% or 60% detection rate. The tumor detection rate significantly higher than trust. 93% of the MR detected tumors are considered clinically significant. And then this is the other thing, over 55% are in the apex or anterior gland, which trust is never going to get. Okay. And then the last slide said only 4 cores. They're taking 2 or 3 cores every time because you're targeting it. You know exactly where the suspicious tissue is. You go after it. So this is it in the predictive value. This is a PSA of 4 to 10. You can see this is third trust. This is second trust, and this is MRI. So these are the tumor detection rate. When you get up to a PSA of over 15, you got about 80% detection rate with MRI. Okay. Go ahead. And another one. Yeah. This is kind of what happens with PSA, right? You got these guys all freaking out that you got something going on, and it's more peace of mind. So a lot of these patients will come in and ask their urologist, you know, you've had 2 shots at this. Isn't there something better than just trying to stab this thing blindly? And they'll refer them to an MRI, because what the MRI does is it gives you peace of mind. You either have something or you don't have something, but you're going to get a definitive answer through MRI. Okay, go ahead. Go ahead. These are all patient preps, exposed biopsy and risks and hardware and software. Okay, so here's the software to the product. Hotspot, wash in, wash out curve. Then they compare it to their other values and their other images. Go ahead again. And then this is the Star Wars looking stuff. This is, you basically have a software, you have a needle guide, which is this right here. This is introduced transrectally, and this is this thing right here. It shows up real clearly on T2. So that's placed in, then they do a scan, then they take the target and they move the cursor to where they want to target. One more slide, and it tells you where to set this device right here, where your settings are, AP, left, right, up or down. Go ahead, one more. So it tells you where to put each one of these settings down there on the far right. It tells you exactly where to put the settings, and then they'll put the needle guide right down this. And fire the needle guide one time, pull it out, and then they'll do a confirming scan. That's it. The interventional portion takes about an hour. You're on the table for about 40 minutes. A lot of it's patient positioning, but they give IV Versed, so most people leave, don't even remember what happened to them. So it's much more comfortable, believe it or not, than trust biopsy. One of the interesting things is, you know, I used to do this with demonstrations all the time and say, this is the needle guide. And guys would be like, oh, okay, not too bad. The ultrasound trust biopsy needle, the needle guide, the first time I saw it, I could not believe it. It was about 4 times this size. It's large. It's not very comfortable. So this is the actual guided device, real time in the MRI, what it looks like on, so they can see, you can clearly see the anatomy and see exactly where you're targeting. Go ahead, Armando. And then the biopsy itself, this is the tip of the needle, so they're making sure they're not in the bladder, and this is the throw of the needle, so it takes a 17 millimeter sample. So it'll take a pretty good sample. Typically, the diagnostic radiologist or interventional radiologist, the urologist will be in the room sometimes, and they'll help plan the biopsy and actually do the firing of the gun, but sometimes the interventional radiologist will do that. And then the pathologists and our technical support, and then there's an MR tech that actually runs the machine that does the imaging. That's kind of what it looks like. And that's the actual urologist firing the gun. Okay. And then this is, go back one. This is kind of their experience. 150 diagnostic prostates. That's gone up to probably 250 at this point. This presentation's a little dated. And then 100 MRI guided biopsies. They average 3.5 cores per patient, 2 complications, 2 procedures. The procedure time is typically 30 minutes. The tumor detection rate 60%. But look at the bottom. They were all reimbursed by third-party payers. So the third-party payers are realizing that this is an important modality because you don't have to pay for negative trust, negative trust, negative trust. You get a definitive diagnosis on one shot. Go ahead. Go ahead. Less course, less pain, less risk of infection, less risk of bleeding, less perceived risk of seeding along the needle track, less cost. MR needle guide is smaller and more comfortable, fast done in 30 minutes. IV Versed is a happy drug. If anybody's ever had IV Versed, it's an amnesiac. So typically you have these procedures done, you don't remember what was going on. And then it's kind of a laser guided bomb versus carpet bombing. So the conclusion of it is it's got a definitive role in detection and localization of prostate cancer. The other reason that there's two other factors that MRI is really key in. One is extracapsular extension. You want to make sure that before you have a radical prostatectomy, it has remained in the prostate gland. It hasn't broken out of the gland and become extracapsular. One of the key ways to find that out is through MRI, because they can get the anatomy of it, they can get the structure. And there is a large group of people at this point that are doing radical prostatectomies without having even found out if it's extracapsular extension. And the way the urologists find out, or the surgeons find out now, is when they get in there. And you can avoid radical prostatectomy in a lot of cases to find out if it's extracapsular or not, because a radical prostatectomy is not going to do you any good if it's extracapsularly extended. So MRI is another way to stage it properly. And then the second thing is, radical prostatectomy, after you've taken the gland, there's also a large amount of patients that have recurrence, have recurring cancers. So that DCE, that wash-in, wash-out characteristic I showed you, think about it, that you can't do a trust any longer. You can't, much to the chagrin of some people, you can no longer do the blind ultrasound because there's no gland there anymore. So they'll do an MRI with the DCE wash-in, wash-out, and they'll see recurrence real clearly on that, because that cancerous tissue still has that characteristics even if the gland's not there. So those are two other uses of it. And then the last use that we're seeing a lot of play on is has anybody had any kind of brachytherapy here? Seeding, radiation deep seeding? Okay, a couple of people have had radiation seeding. The oncologists are real interested in getting where the hot spot is, because what they do now is they just put seeds throughout the prostate gland, and it burns the prostate gland out pretty good. It basically fries it. And if they can get a radiation target through MRI, they can reduce the amount of seeds they put in other areas of the prostate and preserve that part of the gland. So they can burn the area that they're interested in, which is clearly the highly suspicious tissue, and then leave the rest of the gland. So staging, diagnosis, and then for brachytherapy. And then this is fine. Hopefully we haven't confused you too much, but see if the next slide, if he's got visual aids on.
That's it.
Go, that's it, okay. So the next step of this process is now you've got a tool for diagnosis, and you've got a tool for actually capturing what's going on, and then getting a tissue sample. But so you get a tissue sample, is there a way to avoid having a radical prostatectomy? And they're doing some work now with laser therapy, where they'll take this guide, they'll put a laser down through this guide and target it off of MRI, set the laser so it only heats the area that has suspicious tissue, and they'll burn the high index lesion. And they're getting really good results with that, because prostate cancer has been thought for years to have be a multifocal disease, meaning you have multiple lesions that are affecting the gland. But now they're doing some research that have found the index lesion is, in most cases, the one that's really going to do the damage. There's one lesion that does the damage in most of the cases of prostate fatality. So they're burning that index lesion out and having wonderful results with it so far. Again, this is preliminary. Most of this stuff, prostate's a slow-growing cancer. It typically takes 10 years to have any kind of mortality rate off prostate, but this is where it's kind of moving now into this focal therapy, whereas if you can target it and you see the danger, go burn it out or freeze it out, or there's other, there's HIFU, there's high intense ultrasound. There's different techniques, but that's the idea, is to get these lesions and preserve the gland so you can avoid the 20%, I think it's 35% incontinence and 20% sexual dysfunction post radical prostatectomy. So that's kind of the idea of better diagnosis, better staging, and then better biopsies. Any questions or anybody have it? Yeah.
Desert Imaging, the only outfit around here in Southern California that has this capability that you talked about.
Yeah, Desert Imaging was the first. Mission Hospital down in Mission Viejo has this capability. UCI is coming on board in the next couple, probably give UCI probably till the end of the year, but next couple months. UCLA, there's an imaging center up off the 101 called Rolling Oaks Radiology that also has this capability. Anybody else from other
Excuse me, Dan.
Yeah.
In asking questions, we'd like to have people kind of line up and get them on the mic, because that's the only way that we get them on the camera, the sound on the camera, and we don't want to miss their questions so that the answer, your wonderful answers go on camera. You know what you're talking about.
Yeah, the question was, in Southern California, where is this technique being used currently? And it's Mission Viejo, UCI, West Coast Radiology, right off the 22.
In fact, one of Dr. Weissman's colleagues in radiology is a radiologist at a imaging center, a group of imaging centers here in Orange County called West Coast Radiology. And they will be on board in the next couple weeks. And hopefully Dr. Weissman, you'll have a role within that organization.
I would like to ask people to come up here, please, to ask your questions, if you don't mind.
We are also talking to Hogue as well.
Sure, come on up. Come on up here, just line up here. Man. We know you have questions, so come on up. And then speak into the mic so that we can get it on the tape. Right here's fine. Just come on up.
I have two questions. The first question is, what is the role in watchful waiting on this? So if somebody has a biopsy which was positive, but it's of a low Gleason score, is it something that you can do periodical MRIs and then say, hey, this isn't very large, or it isn't changing a lot, or do these things metastasize without getting real large?
That's an excellent question. Dr. Weissman could check me on this one too. I just saw a presentation at the PCRI Cancer Research Institute recently that a Gleason 3+3 in known literature has never killed anybody. So they'll put a 3+3 on watchful waiting to see if it moves to a 3+4 or a 4+3. So you can periodically get an MRI every year and get a tissue sample where you get a Gleason score. Even with your PSA rising, you can still get an MRI every year, or whenever they feel like that, there's something that the PSA has gone to a point that's dangerous or something that they can't explain. Sure, and the thing we always say is, if you have radical prostatectomy, that's kind of the end game. Why not start with some of this, diagnosis or different modalities, and then as it progresses, you can always opt for radical prostatectomy later. But men at this point seem to lean towards radical prostatectomy early in the diagnosis without having a definitive diagnosis. So
The other question I was going to ask you is that the problem with PSA is a lot of people have a high PSA and have other causes, and it's a non-specific test. And with the rate that a third of the people over 50 are going to, on autopsy, have some kind of abnormality to the prostate tissue. It's a it's a shocking number. I never realized how large that was. By the time they get to 80, 85, I think it gets up to 85%, and there are Gleasons that are relatively high. And the question is, the harder you look, the more you find, the more is going to be done to people. And you wonder, with this prostatectomy procedure, it seems to be perhaps worse than the disease itself. And I certainly applaud the ability to look.
yeah.
But I wonder whether the doctors are smart enough to put this into perspective and to differentiate between those people that need something done versus those people who don't. I mean, it really, as a person who has a low Gleason score, it goes through my mind, should I do something or leave it alone? And unfortunately, the urologist wanted to do a prostatectomy, and then I saw an oncologist, and he said, gee, if it was my prostate, I wouldn't do anything yet.
This is where Dr. Weissman can kind of either close his ears or be okay with what's said here. Urologists remember our surgeons, and kind of the analogy we use is when you're a hammer, the whole world looks like a nail. So their immediate thing is to go into surgery. That's what they do. They're surgeons, and it's one of the few cancers that are diagnosed and treated by surgeons. Most times you're going to go to an oncologist and you're going to get some kind of path of dealing with this, and surgery is certainly an option. And I don't want to rule out surgery ever, because surgery has applications on a lot of opportunities with this. But to start with radical prostatectomy, I think is doing a disservice to some of the diagnostic tools out there. And again, things are changing all the time. This modality has changed in the last 2 years drastically. They're finding all kinds of new stuff. And this is constantly moving. And that's why programs like this are really good for the community, because you're keeping up on the latest. Who knows? There's antigen tests that are coming now where they can do blood markers and blood biogen markers. Well, they'll just get blood tests and they'll find out exactly what it is. So there's a lot of stuff that's moving towards the next step. But to start with surgery, with a radical prostatectomy, I think does the patient a disservice. You're welcome.
Thank you for the information and good presentation. I have 2 questions. The first question is, there are people here that belong to HMOs, and the cost is a factor in that kind of situation.
Yeah.
Now, I know you can't give me a specific dollar amount, but what would be a range you could expect in terms of having this particular type of therapy?
The reimbursement, I only know the business side of it. I know the reimbursement side. I don't know the patient payout side. The reimbursement side of it is typically an MRI costs for prostate somewhere in the neighborhood of, do you have any idea, Dr. Weissman?
I think Dr. Feller said his reimbursement from Medicare was something like $700 to $900 for the study and $250 or $300 for the biopsy.
So
Yeah.
$1,000 cash.
Yeah, it's about,
1,000 cash.
yeah. The good news is that Blue Shield and Blue Cross have not held any payments back on any facility that's doing this procedure. And that's interesting, because in a lot of modalities they do. They'll wait for the modality to catch, and then they'll say, well, we have to pay. This one they're saying, we'll pay right now, which is kind of different. And I think the reason for that is they see the big picture. If you can avoid radical prostatectomy or avoid multiple trusts, you're paying for all of that, and that's big money. I know a radical prostatectomy, typically for the urologist, is reimbursed at about $6,000.
So let me make sure I have this correct. So an integrated process where they utilize your technology, MRI, a biopsy is somewhere around 1,000, is that what we're saying?
Yeah.
Second question, someone from the audience asked me if I would ask the question, the MRI in your presentation, was that an open or closed?
That was a closed MRI. Yeah. And the interesting thing about MRI, and one of the reasons it hasn't, when you ask who's doing this in the area, at the beginning of this, there's something called a transrectal coil, which is a balloon that they put in transrectally. They inflate the balloon, isolates the prostate, then they image the patient, and then the patient leaves. That's a diagnostic test, right? So you've got the tech putting the balloon in, who techs typically don't like doing stuff like that. It slows down their day. They're doing knees, shoulders, elbows, brains on this MRI machine all day long, and then all of a sudden this patient comes in, they got to inflate something in their rectum. They have to have it on the table a little longer. It just ruins their throughput, not to mention it ruins the patient's day. So that was the initial thought. You had to have all this for imaging. But as MRI machines have gotten better with their gradients, now you just put what we call a surface coil. It's an RF coil in the front and back. You put it kind of like a diaper, and you go in and lay on the table, and they can image that way. So the early adapters started with this endorectal thing, and we have done a pretty good job of showing images. That particular image that I showed was on a 1.5 closed magnet with 1.5 Tesla with no endorectal coil. It was just a surface coil. So they could get images, do the diagnosis, and do the actual biopsy without having to have anything put in transrectally, which is a big difference.
The MRI for the prostate needs to be done in a closed magnet right now because the technology for the open magnets, for those of you that are claustrophobic, and I'm curious, that's why I'm wondering why the question was asked. The technology doesn't exist for those open magnets to give a good enough picture of your prostate for it to be a diagnostic, of diagnostic quality. So if you're going to have one of these exams done, it needs to be in one of those closed magnets that look like a big donut.
Now, the good news for everybody is these closed magnets for years used to be, it was like being buried alive. We used to get in there, you know, to do test things, and you're like this next to the thing, and you hear these loud gradients. Really a horrible procedure. Anybody that has any kind I'm not claustrophobic, and I became claustrophobic by getting MRIs done. So the good news on that is they're going with wide bore magnets now. So they're smaller, the bore is actually shorter, and they're wider. So there's air, there's movement, you can see out the back of them. So it's not that same MRI that there were years ago where you would just basically put in a tube like a submarine and told to hold still for 30, 40 minutes. So that's the good news on that side.
My question, I have about 3 questions. One is, you know, I go to a pretty well-known urologist at Newport Beach, and I'm curious why a lot of doctors don't seem to know about this. He had no idea about this capability, for example. And so I heard about it, that's why I came tonight, and then I guess he'll write me a prescription for it, but he didn't have any idea about this capability. I'm just wondering, apparently this is not widely known, even among urologists.
Do you want my politically correct answer, or do you want, or do you want the off-mic answer in the back? Here's the thing. Urologists are paid for trust to be done in their offices, and it's reimbursable, and it's something that they're accustomed to doing, and they control the patient. They can bring them in whenever they can, and they can do as many as they want, and that's reimbursed. They know that piece. That piece is easy for them. They do it every day, all day long. The part of having a patient now go to an MRI and have something done that possibly could show that trust wasn't the right thing to do, maybe that's part of it. For some guys, it's a conservative. It's a very conservative field, urology. Not all of them are as wide open as Dr. Weissman. It's a very conservative field. So there's a lot of people that hold on to that trust as this is just the way it's done. It's like like I said, I've been selling medical for 30 years, and I've done a lot of different parts of this. And any new modality takes a long time for the early adapters to prove to the late adapters that this is a better mousetrap. So some of it's that. The other part of it is, yes, there's a lot of education that goes into this, and that's why we do forums like this. And this is going to be one 2020 or Oprah away from really opening a lot of people's eyes, because I don't think a lot of patients know this is available. And I certainly know there's a lot of docs that don't know it's available. But you have to want to be educated. I found over the years that you have to want to become educated to what's new out there in order to know the latest. So the question is a very valid question. There's a lot of people that will say, I don't know about this. But it's not because Armando hasn't knocked on his door 30 times saying, hey, there's a new modality for prostate cancer treatment. Do you want to learn about it? So there's got to be a little bit of both. And I think this is going to become more patient-driven than these guys realize.
To add to that, what Dan talked about earlier today about prostate cancer being very analogous to what breast cancer was. 6 or 7 years ago, when I started with this company, selling this product for breast MRI, there was only a handful, I can count on one hand, of hospitals or imaging centers in the area that I cover, which is Orange County, San Diego, Riverside, San Bernardino. 6 or 7 years ago, there was only a handful that offered breast MRI services. Hove being one of them, St. Joseph's being one of them, but none of the smaller community hospitals, very few of the small outpatient imaging centers. Today, there's not a single hospital in the areas that I cover, for the exception of Kaiser, who's a little behind the times, that doesn't offer breast MRI. So, to your point, 6 or 7 years ago, not everybody offered breast MRI services. Today, everybody does. So to Dan's point, there are early adapters, which are the mission hospitals, the West Coast Radiology, UCLA, UCIs. We feel in 3 or 4 or 5 years, this is going to be in the same place where you go to every hospital and they're offering some type of prostate MR capability. Whether it's biopsy or not, who knows, but we'd say in 3 or 4 years, this is going to be a standard of care.
Okay. My second question is, you quoted about a 60% success rate in catching the cancer, and does this depend on a lot of experience? For instance, out from Springs Desert Medical Imaging, they've done it a long time, had a lot of experience. You mentioned a number of others that are just coming on board, like Mission Hospital and Irvine and West Coast Radiology and Hope. But are they going to be as good and successful as Desert Medical Imaging, because they've been doing it a long time? What's the situation?
Yeah, that's a really good point, and that's exactly it. It's a learning curve. It's like any new thing that you take on. Some of these guys will adapt to it like that, and they'll be really good at it. I mean, radiology is kind of an artistry anyways. There's, everybody likes to think that their doctor's the best doctor and there's no bad doctors, but somebody ended up last in his class somewhere in his medical class. So, and that's one thing you learn of being in this business so long. You get a little jaded because you know that there's the best and you know there's not the best. It's just the way it is. And I think as a patient, you think your doctor has it all down. But there is a learning curve, and it's interesting how quickly they adapt to it. But actually reading it, is not as difficult as most of these studies are. If you take all 3 of those modalities, and that's why we give them DCE, and that's why we give them these T2s, and you take all these things and you line it up and you say, it's dark there, it's light there, and it has a wash in, wash out, you might want to think about going to do something with that. So it takes a little of the guesswork out, but it's still an art. It definitely is an art.
Can you get an equivalent Gleason score with the curve? Can you get an equivalent score? Has it gone that far?
Yeah, no, not yet. With the Gleason score, it's tissue. You can only get a definitive diagnosis through a tissue sample. That's the only thing you can get a definitive diagnosis. Now, they're doing studies with that ADC mapping, and there's a correlation. There is definitely a correlation of the Gleason score versus your ADC values. There is definitely something there, these B values. But the only way you can get a definitive Gleason score is through a tissue sample.
Okay, last question. How does this compare with color Doppler ultrasound? Apparently it's better. Is that true?
Yeah, again, let's look at our signs. I mean, I know Dr. Duke Bond was somewhere on the docket. Has he spoke yet, or is he going to speak?
He has spoken.
He has spoken.
He periodically comes here about once a year.
Okay. So I don't want to step on any toes with Dr. Bond. The one thing I will tell you is, with Doppler ultrasound, you're taking 2 modalities. You're taking ultrasound and then you're taking a color map and putting it over, and you have to line it up right. It's 2 different modalities of looking at something. That's different than what we're saying with the wash-in, wash-out curve. So there are some really interesting things coming out of Doppler ultrasound. It is definitely a tool to be used in certain situations, but you're still doing an ultrasound. It's still the same needle. Now you're getting a better target, but you're still got that 1.7 millimeter trajectory. And there's a lot of guys that are doing some high-end stuff at UCLA, like what Dr. Weissman and I were talking about, and they're still ending up getting MRIs for a definitive diagnosis that they're missing in Doppler ultrasound. That's the only thing I can tell you. There's not one better than the other, but they are still getting definitive diagnosis off MR that they're not getting with Doppler. So it's a better mousetrap, but not quite there yet, I think, with Doppler.
I had a couple questions. I had a color Doppler with Dr. Bond.
See, that's why I don't throw them under the bus, because there's always patients at Dr. Bond.
But then 2 weeks ago, I did have an MRI at the Huntington Hospital in Pasadena, and I believe it's an up-to-date machine. It was the short pad, I could see in the back. But I didn't have the rectal coil, they didn't do that, nor I didn't know what you meant when you said this, but they did put a plastic thing on top. Is that the same?
That's an RF coil, right?
Okay, so I probably would have gotten a diagnostic MRI at that time, but so when I had my results, it looked like they took Dr. Bond's biopsy and updated it per the MRI, but I thought I would be getting a more definitive results out of the MRI, like the curve and the wash and wash out. So
Yeah.
I'm going to go back to him and talk to him some more, but
The piece that was missing with that, what you just described, is that you can do an MRI, you can do the imaging portion, you can do the T2 weighted imaging and the diffusion with the water motion. The piece that's missing is the diagnostic, we put the GAT in and they watch the wash in, wash out. At Huntington, they don't have a CAD system for that right now. So they weren't looking at that third piece to try to find the hot spot off that. So you can still get an MRI for the prostate. It's just going to give you anatomical features and it's going to give you hopefully something bright or dark on T2. That's 2/3 of the picture. The third piece of that is going to be that DCE wash in, wash out curve. So it could be that they could catch something on the first two components. You know, there's about a 70 or 80% accuracy on that. But when you add that diagnostic DCE, that's the big piece. That's the piece they might have been missing.
what came out of it was I had more mass than Dr. Bond had saw, so that was informative. The second question I had, you talked about techniques of using laser to target tumors.
Yeah.
Is that in clinical trials, or are they actually practicing that now?
No, you're right, that's clinical trials. It's been FDA approved for clinical trials. It's been used in the brain for years. It's FDA approved and being used in the brain to do tumor ablation, but now it's being tried in the prostate.
Okay, so it'll be years before it gets out? Or?
Typically 2 to 3 years, yeah. But again, if you contact these places that are doing it, they'll know about the places that are doing the ablation. You know, Mission knows where there's ablation being done, even if they're not doing it, they know where to send you. And then the other thing is to educate the urologists in the neighborhood about what's going on and what's available and where to send people. That's the other piece.
Okay, thank you.
You're welcome. One of the things I wanted to mention too that before we get to the next question is MRIs are expensive. There's only a certain amount of MRIs in the country, and they usually are used for brain and ortho work and that type of thing, so they're very expensive to do. So to use this as a screening tool without any kind of trust biopsy or without any kind of prior diagnosis is probably not ever going to happen. You're probably going to need either a general physician that says, you know, rising PSA, I've done everything I can do, go get an MRI, or a urologist to defer you to get an MRI. Unless you want to walk into an MRI and pay cash, I don't see the reimbursers, the third-party reimbursers saying, we'll use this as a screening tool. Just like they haven't done with breast. MRI for breast cancer is by far the best modality, but they still require you to first get a mammo. If nothing's definitively found on mammo or something suspicious is found on mammo, they'll send you to ultrasound. If something's definitively not found on ultrasound or something suspicious is found, they'll send you to MRI. So that's kind of the progression with breast. They don't use MRI for breast screening in this country just purely by the cost. So that's kind of where prostate I see is heading to. You're going to need to have some, I don't know what this is, go to the next modality before you can get reimbursed for it. Yeah.
Just a couple points. I have an appointment next week at Rolling Oaks for a diagnostic MRI.
Wonderful.
Somebody asked about the cost. My co-payment is $200, or whatever that's worth.
Okay, wonderful.
The other point that caught my attention was Mission Hospital does this test. I live in Mission Yale, and I'm going to 1,000 Oaks for this test. That's, I guess, a question for my doctor tomorrow morning. My other real question is, though, from what I'm hearing, and clarify on this, I'm having the diagnostic, not the biopsy.
Right.
It seems like, from what I'm hearing, it's pretty non-invasive as far as
the diagnostic, yes.
Yeah, a rectal probe or any of that.
Correct.
Is that correct?
Now, here's an interesting thing that you might want to know before you talk to your doctor tomorrow. Rolling Oaks does use an endorectal coil. They'll put you on a 3T magnet and they'll put an endorectal coil most of the time. 90% of the time for a diagnostic, they'll use an endorectal coil. I don't believe Armando Mission uses endorectal coils. They're using surface coils.
Yeah. Mission does what the gentleman who was up here before. They put what we call an RF coil, but it's basically a plastic contraption that wraps around your waist. And and that takes the images of your body. So it's not as invasive as the endorectal coil, which actually goes inside of you.
Okay, so it does not go inside of you.
If you're going to Rolling Oaks, that's their preferred method.
Yeah.
If you'd rather not do that, Mission offers a non-invasive way of doing that. And one of the reasons Mission is able to do that is because they've got what's called a 3 Tesla magnet, which is the most powerful magnet in the marketplace today, which takes the best images. So if you equate it to a camera, it's the highest resolution camera available.
So
Who's your doctor, by the way? Who's your urologist?
Dr. Mark Schultz.
Okay. Yeah, that explains, okay.
Okay. And Dr. Schultz probably knows the doctors up in Rolling Oaks, and maybe he's very comfortable with them. And the doctors at Rolling Oaks have been doing this for a long time. They've been doing it for 2 to 3 years. So
I was only looking at it from a 2.5 hour trip.
Oh, sure.
Yeah,
10-minute trip.
Yeah.
To Mission.
Well, here's the interesting thing you're going to be faced with is like Armando said, Dr. Schultz has got a good referral base with Dr. Princenthal, who does the reading up at Rolling Oaks. Dr. Princenthal has probably read over a couple hundred of these. He's done a lot of biopsies. He's using a 3T magnet with an endorectal coil. Top notch, definitely top notch. Mission has adapted to this. They were installed and have been up and running now for about 6 to 8 months, but they're using surface coils and they're having good results too. So if it's a drive thing, you got to weigh that. Do you want to go with Schultz's recommendation, somebody who's used for a long time with a lot of patients, or do you want to go someplace that's closer, maybe for the first shot? That's a decision you got to kind of weigh. But I think both are going to be fine for a diagnostic.
Well, part of the invasiveness of it was they recommended a fleet enema prior to going up there.
That's why.
That's pretty invasive. That's pretty.
That's
That may be
why.
the worst part of it.
Yeah, that's why. That's why.
But that's normal.
Yeah.
But doctors at both places are fantastic. Dr. Lempert is the doctor at Mission Hospital.
Doctor who?
Dr. Lempert, Lempert, Todd Lempert. And West Coast Radiology, which is, they've got, I think they're going to be doing their procedures in Irvine. There's a Dr. Joseph Brugman, who is a colleague of Dr. Weissman. And Dr. Weissman, I think you've known him. Sure.
Can you use the...
Yeah, throw that mic on.
At Mission Hospital, it's Todd Lempert, and West Coast Radiology, which has centers in Santa Ana, Irvine, and Mission Viejo. It's a Dr. Joseph Brugman.
I'd like to know if this MRI diagnostic tool is being used for people who have had prostatectomy already for additional cancer, either in the prostate bed or the seminal vesicle bed, or even in the lymph nodes. Is this modality being used?
Yes. For recurrence, it's really good to find the recurrence because you don't have a prostate gland anymore. So that's the first thing, that DC, wash in, wash out. That'll show up brightly. The second thing is you've got the anatomy, so you can do a lot of staging with this. Most of the time, though, I think PET is the definitive for after radical prostatectomy.
Well, there's a variety of things, but currently the new PET with sodium fluoride is being done. Mark Schultz sends patients, and they're doing the new one is sodium fluoride.
Yeah.
PET. And that's available at West Coast Radiology.
Okay, so the PET is, they basically put a radioisotope in, and they look, that radioisotope will attach itself to cancerous tissue, so they'll do a whole scan of the area that they're interested in, and they'll find out where that radioisotope attached to, and that's the metastasized stuff that they're looking for. So MRI with combination of PET CT is used.
So the combination would be good even if you had the sodium chloride? Thank you.
You're welcome.
I think that,
One more question behind you?
oh, behind me, I'm sorry, John, go ahead.
One of the things that is not mentioned very often as to why men end up with a prostatectomy is the pressure that we receive from family. When you have 9 siblings and they call you once a week and say, have you gotten that tumor out of there? And it just works on you, especially if you don't have a support group like we have here tonight. And then, it's not a warning, but my urologist was a very well-known urologist in Newport Beach. And when I ended up totally incontinent, and after I saw the experts and they could not help me, and I talked to him, he said, he was amazed. I was his first patient who ever had, were incontinent. He said, you don't hear of it. And I can't tell him he was lying, but I can tell him, you know, what I've learned here. I don't think he was my friend. Thank you.
You're welcome. That's a really good point, and that's why we're kind of passionate about doing these type of forums, because education is the best tool for this type of thing. And again, the first, we hear that all the time. I went to the urology, their national meeting, the Urology Associates of America have their meeting, and in the exhibit hall, 50% of the exhibit hall is companies that deal with urinary incontinence and sexual dysfunction. Viagra had the biggest booth in the whole thing. So to not hear about it or to not know about it, the numbers are 20%, 35%. Those are documented numbers. So to not know if there's other modalities out there is one thing, but then to not have the information is the key. So we really appreciate your attendance tonight, and these are the type of forums that it's going to change the way this stuff is done right now, because you don't see the football players wearing the purple stuff and selling the wristbands and everything on TV. You see them wearing pink, and breast cancer awareness is very, very high profile in this country. Most people don't know when Prostate Month is, or what color it is, or who's supporting it. The funding is phenomenally different. The breast, I don't have the numbers on one of the slides, but the breast funding versus prostate cancer funding, it's almost 4 to 1. Just because women have done such a nice job of marketing it and selling a need for a cure and better outcomes. And that's what it comes down to. And again, as men, we haven't organized, we haven't put this together. There's many members of Congress that have had rising PSA or radical prostatectomies, and we do a forum back in Washington every April, and it's the wives of the congressmen that show up. The congressmen don't even come to listen to what's new out there. It's the wives that come out, and they take the notes, and they push their husbands to try to pass legislation for better funding. But this is where it starts. It starts with better education for the community, and then you can take that to the doctors and say, do you offer this? And if you don't, I'm going to go find somebody that does, so I can get a definitive diagnosis. So thank you very much for attending tonight. It's very important.
Okay, we would like to thank Dan and Armando very, very much. And the synopsis of this is that there's something in this a presentation for everybody out there. I was afraid at first it was going to be for newly diagnosed and nothing for the advanced. But they allayed that and said, hey, there's something for the advanced here people too. Now, I have told you before that we don't spend a lot of money on our staff. We don't spend any money on our staff. I told you what. We really go to great expense, though, to bring these speakers in. We present each of them with a Prostate Forum cup because when they're driving, their schedules are very tedious, and they have to do a lot of their breakfast time in the car when they're going from one place to another. And these cups are designed to fit in the car with the lids that don't spill. So we give the best of the best to our presenters. Okay, I'd like to make one quick announcement before we leave, and that is next month Next month, we're not going to meet with this meeting on the fourth Thursday of the month. We're going to meet on the third Thursday of the month. And the reason for that is, if we tried to meet on Thanksgiving Day, I would hate to see who would attend. So, the third Thursday of the month, and we don't have a designated speaker that time, but this is one of our favorite things that we do throughout the year with some of the people, is we divide you up into about 6 groups of subjects that you have a particular interest in. Whether you're interested in prostatectomy or brachytherapy or whatever, you don't have to listen to just one speaker for tonight for the whole group. We'll have 6 different concepts for you to come and find out about what you specifically want to find out about. So come on out the third Thursday in November, and we'll try and address your concerns specifically. That's all we have tonight. See you next